I will try to make a short presentation. I mean, we know each other. We met the previous 2 days. But in this session, I would like to present to you the research that we are doing with Sterios in the lab. Also in line with what we will start here in Greece with Archimedes. So yes, I will try to give an overview of actually the main motivation on the topic that we are working on, and some more technical or more engineering-based advances that we have currently. And at the end, I will just present and discuss with you our ideas about Archimedes. So I guess more or less this is something that we are discussing through the entire summer school. Everybody is discussing about AI and how this can affect precision medicine. But actually, if we want to do a kind of to have a kind of definition about what precision medicine is, we can say that it is actually the methods or the domain that tries to identify phenotypes of the different kinds of patients and find out how well treatment will respond to with respect to the particular phenotypes. And indeed, the last, let's say, 5-6 years, there is a lot of attention on how we can use AI to do this kind of stratification, to identify these phenotypes, which on one hand they can be actually they can be guided of things that we do currently in the medical and the clinical practice, or they can be actually something new or some kind of new biomarkers that we can identify through by just using a lot of data and a lot of kind of different kind of information. And indeed, this kind of research and studies that shows that AI can actually have an impact on precision medicine, they are actually summarized on very high impact journals, like for example Nature, Science, and so on. And we can see more and more these kind of tools that they are integrated on really medical and clinical problems. And actually in our lab, what we are focusing on how we can develop AI tools for cancer. And in particular, we are focusing on cancer because, as everybody knows, it is actually the leading cause of death. So we have a lot of people that they are really develop this disease. And of course, even now, we miss some kind of deep understanding, not on the biological side as well. We know some things, and we start to know more about how cancer is involved, how we can deal with it, and so on. However, there are things that they are not really known. For example, how it develops, how the metastasis is happening, and so on. All these kind of mechanisms, it is actually a very active field of research currently, and indeed AI can be integrated into the way of how we can actually identify this kind of mechanisms, and they can actually try to do some kind of better stratification of the patients with respect to different characteristics. And of course, since cancer is very complex and actually the decision is really depending on a variety of things, it is something that we have to keep in mind that we don't really, if we want to develop AI or methodological algorithmic things for clinical endpoints, sometimes maybe having the decision only in one modality, it's not enough. Since we know that information that we need in order to do this kind of certification, it comes on different kind of scales, from, let's say, high scales, like from radiology images. We know that heterogeneity, for example, the size of the cancer is very important for the progression and the patient. We know as well already currently that genetics contain a lot of information. They are already used in clinical practice to stratify patients on treatments, especially immunotherapy, depending on the type. And especially depending on the type, different kind of genes are checked, even today. And of course, we have the finest scale, the digital pathology, which is actually tissues that they are extracted from the regions of tumor after the surgery. And indeed, this is actually the modality that we use in order to do the kind of really stratification of the patients on the particular subgroups. And of course, if we really want to focus on more clinical questions, how we can combine all this information, or how all this information affect each other in a more like complex system, it's something that is very important and very difficult to design. So indeed, there are a lot of things that we can think of, and how we can integrate all this kind of information. And here, one more thing that I want to mention is that, and you need to keep in mind, is that we are talking about data that they have a super high dimensionality. Having to deal with all this kind of huge dimensionality, and on the same time do not have a lot of data, or having data that they suffer from biases, from things that we saw in the previous lecture, it can add also a lot of difficulties on the development, and really development on the methodological side of all these tools that we want to really have for the clinical to assist clinicians. And actually, in our group, we are engineers, so we are more on the methodological side. We are really working with doctors, so all the kind of data and questions that we want to address, they are coming from the doctors that they have the knowledge. But in our part, what we do is that we are trying to develop the best algorithms that they can deal with this kind of data for these problematics. So in our group, we are working on, in general, medical data, and me and Sterios, we are specializing on medical imaging. And we are actually trying to tackle things that they have to do with small size, missing annotations, things that we have to deal with when we are using this kind of databases and clinical trials. Big range of variations and annotations. We are trying to really develop algorithms that they can deal with this kind of problems. And of course, biases that they affect the predictions. We discussed that a lot in the previous sessions, but for example, there was a recent paper that shows that from X-rays, female cancer patients with lung cancer, they had the worst diagnosis and worse performance of the algorithm than male ones. So indeed, we need to really keep in mind all these kinds of limitations in order to be sure that we can actually develop tools that they are useful at the end. And now, with respect to the tools and the methodologies, we are focusing on weak and unsupervised learning. So types of learnings that they are not really need a very big amount of data in order to be trained. Generative modeling in order to create and generate new data that they can serve for different kinds of purposes. Reinforcement learning, since again we don't need a lot of data to train algorithms with. Since also we are talking about progression of disease, we are also working on how we can model temporal correlations between follow-up follow-up exams and so on. And of course, multimodal learning, because as we discussed, it is very, very important, especially if we want to have clinical endpoints. But in this lecture, what I will focus on is some work that we have and some kind of motivation for digital pathology, which are this kind of nice images that you can see in this slide. And I will start by trying to describe what is actually digital pathology. So overall, digital pathology is the modality that it is used actually for the stratification of the cancer patients. After the tumor is removed from the patient, we use this tissue in order to stratify and classify the patient in a particular group, and with respect to that, we decide, the doctors, not we, about the most appropriate treatment that he needs to get. So overall, again, you can see here we start by the surgery, and then we have some kind of processing of the tissue that it is removed. And this tissue, it is actually analyzed under a microscope. So by experts, and these experts, they write a report about the findings and the type of cells that we can find, and with respect to that, the patient gets further treatment. And actually, all this kind of pipeline, it is something that is happening even now. But currently, and from 2017, we can have these images, this tissue, in a digital format. So actually, this kind of research started to be very active, because now we can actually have, we don't really need to rely only on one expert that will take a lot of time to analyze in a clinical practice all these kind of patients, but we can actually provide tools that they can somehow assist the process. And how these tools they can be they are interesting for. They are interesting for computer-assisted diagnosis. We discussed before about doctors that they will use AI and doctors that they will not use AI. But I hope that at least there will be some kind of clinical routine that these kind of tools they will be able to be assisted to be in the hands of doctors in a more everyday practice than now. And for this kind of diagnosis, we have problems that they are focusing on classification, like what kind of subtyping of cancer is in this tissue, detection, where are the cancerous regions in a particular tissue, segmentation, more precise identification of these regions. And of course, we have also things that they have to do with the content and how we can actually use this AI for diagnosis, education, and research in a most like image retrieval setting. And of course, as we discussed, the fusion is very important, how we can fuse these images together with other very, very important information like genetic information. And how these images they look like, they have a huge dimensionality. They are very, very big data. One of these images can have a size of couple of gigabytes. So you can imagine that it is very computational heavy to process this data. And actually, of course, since their dimensionality is super big, also having annotations or very, very precise annotations about the problem that we want to address, like the different kinds of cells that exist on the particular tissue, it's something that it cannot happen. It's very time consuming. We don't have the means to create this kind of annotations. So and also, if we have it, it's a lot of times suffers from inter-observer variability, meaning that different experts can have different annotations and different decisions for even exactly the same sample. So all these add a lot of challenges of the histopathology, and on top of this, we have different kinds of microscopes and hardware that analyze this data, and together with different kinds of stainings that they are used from different hospitals in the clinical practice, and all this adds a lot of variability on how this tissue looks like. And of course, when it comes to AI, this adds additional kind of problems on how we can be sure that this kind of processing or these models work well in this kind of different setting. And how actually this data looks like, they are super, super small. They are placed on this kind of small glass that you have a very thin slide of the tissue. And these are actually afterwards stored in the data banks of the hospital. This is a photo from the data we are working on the hospital that we are collaborating in Paris. And from this, of course, you can think, you can understand that digitizing or analyzing all this data, it's something that is impossible. So there is also a lot of kind of questions, which things it's maybe more interesting to start with, or what kind of subgroups maybe we should focus on, and because otherwise we will not feel, I mean, it's impossible for people even to do the work to digitize them, but also storing them. Each of these small glasses, it has gigabytes of size. And on the computational side, how we can process this kind of data, we actually have these huge images, and the first thing that we are doing is that we are removing the background. We don't care about this kind of white background. We only care about the tissue that exists on it. So, and then after that, since again this tissue is super huge and it doesn't fit on the current computational resources we have as it is, what usually we do is that we are cropping it in small patches, choosing a particular kind of zooming or magnification. And these kind of patches later on, they pass from a kind of pre-processing pipeline in order to normalize and fix all these kind of issues that we discussed before. And then we use some kind of learning, which is called multi-instance learning, on which we don't really have the label for each of these small tiles that we have extracted, but we have a global label with respect to the entire tissue that we have. So from only this weak label, we are trying to generalize and to build algorithms that they will be able to analyze the entire slide. And how we can do that? Now we are in the last 10 years, deep learning exists, it is here, it has a very huge hype, but also, except the hype, it can give us also very nice representations that they are learned directly from the data. This is something that is very important for us, because they can actually reveal or identify different kinds of things that maybe we wouldn't be able to identify if we had to decide for that. And the most popular architectures that they are used for image processing is the convolutional architectures, things that we programmed as well in the second day of the summer school. I hope you remember. And this kind of this kind of architectures, which you can choose the one that you like. There are different ones in the literature. They can actually extract this kind of representation from the tiles or from the inputs, and then later on we can use these representations for any kind of task that we want. And also there are recently, and the last 2-3 years, there are also transformers that they work in a different kind of way, that they are also they can also learn deep representations automatically from the data. So also they are really integrated now in the processing of this kind of data. And one of the classical methods, or let's say the baseline that we are using now in order to process this kind of data, and this is actually, it has been published on 2021, so not very far away, in the Nature Biomedical Engineering. It is just implementing this entire pipeline, so we have it automatically. And we have all this kind of data, we have the functions and all the code to tile them, to remove the background, to extract features from this kind of deep learning models. And from them, later on, we can also have a kind of classifier that can give us the final prediction. But in this kind of settings, most of the times, we are starting by using convolutional networks that they have been trained on huge amount of data, that they are actually not necessarily medical data. They are data from computer vision applications that we have actually access in a huge pool of data. So in this kind of pipeline, we are using a ResNet 50 network that it has been actually trained in completely different tasks. And in this paper, what they saw is that by using this kind of pipeline automatically, they could actually perform very well on different kinds of tasks, as for example, cancer subtyping. They were very good on classifying different kinds of lung subtypes, just by taking the entire the initial the whole slide tissue. And actually, in our group, we are working also on this, and we have a kind of project on try to analyze this kind of huge images. But on the end, we want not to have a kind of subtyping of which type of cancer this tile belongs to, but we are trying to associate it with some other kind of biomarkers that we know that they are interesting, as the CDA level, that we know that it correlates with the response to immunotherapy. And again, you can see that even if the clinical endpoints change, the entire pipeline that we can use is very, very similar, with only small modifications. And at the end, we can, doing such a baseline, we can first of all have a prediction about the level of this kind of biomarker from the whole slide image. And on the same time, we can have a kind of attention map that actually give us the most, or indicate to us the most important regions or the most important tiles that actually the algorithm is focusing on in order to take this decision. So overall, there are a lot of kind of applications and a lot of kind of models that we can apply such technologies. However, again, as I told you in the beginning, these kind of representations that we are using, they are usually pre-trained on data that they are irrelevant to this task and the problem that we are working on. And actually, they can work and they can give us something that it is good. However, they are really data and task agnostic. They don't have any relation both on the data and the kind of endpoint that we want to solve. So actually, on this, there are a lot of papers and a lot of methods that they are trying to think about self-supervised or unsupervised methods so that they can be used in order to pre-train these architectures without labels, just on a huge pool of data, that they are data similar to what we want to use at the end. And then we can use these features for the endpoints and not the features that they are completely different to the data that we are working on. And actually, in our lab, we have a lot of work on this kind of axis, and we have, for example, work that we are trying to create self-supervised tasks in order to create representations for classification tasks, as for example in this paper, or even to use some kind of self-supervised things in order to create segmentations and to create features and algorithms that they don't use annotations, and they are very good on really pixel-wise predictions. And however, even if we can do that, we can have some things that they are more data specific, but again, we don't really know how well they work. And actually, something that is happening now in the deep learning community, and it is quite recent, is this kind of large deep learning models that they are actually developed the last 2 years, I would say. And they can actually have super good performances on very important and interesting tasks. So, for example, maybe you know also, on 2021, there was some people from OpenAI that they developed this DAL model, which is a huge model that has 12 billion parameters, and it has been trained on huge amount of data. 250 million pairs of text and images, data that it's not very easy for all of us to have access to and to store and to process, but they managed to collect all this huge pool of data, and they trained this model in order to be able to create images that they look very realistic, and they are actually in pair with the description that we can give to the algorithm. So indeed, that was super impressive, and these kind of generations, we couldn't achieve them before. So people were really impressed and interested on this kind of technology. And after that, people from the same group, they developed GLIDE, which is actually one similar algorithm that it has been trained on 3.5 billion. It has actually 3.5 billion parameters, and it has been trained on exactly the same data set. And again, they changed some kind of technology with respect to DALE, and indeed, the generation of the data with respect to the caption and the text that we were giving, it was really impressive. However, something that some researchers that they are working on the medical field, they try to show or they try to understand how these models they can actually generalize on medical data. So actually, this group on 2022, it performed a study on which they just took this kind of pre-trained algorithms. They didn't change anything at all. They used it as it has been trained on this huge amount of data that, again, not all of us have access to. And they ask the algorithm to generate data, images that, for example, have the heart and it has a histopathology modality, or to generate an MRI, a magnetic resonance imaging of the brain. So actually, they gave all this kind of different anatomies and modalities that we wanted to generate. And what they saw is, and I guess you can also observe in this slide, is that these generations, they were not as good as when we were asking the algorithm to generate cats, dogs, and other kind of things that we can understand. They were really not super realistic, and definitely images that we couldn't use in medical problems. And actually, in order to benchmark this and in order to understand how good or bad the algorithm performs, what they did is that they asked some experts to give a score depending on the generation of the image. And what they saw at the end is that actually the experts, they gave a high score, like a good generation, in the case that the images correspond to a histopathology or a scientific poster or scientific illustration, maybe data that they could be easier accessible in Wikipedia and on the internet. But when the algorithm was asked to generate more medical-oriented data, as for example X-rays, MRIs, and CTs, these scores were very low, meaning again that it is very difficult now to use this kind of algorithms as out-of-the-box algorithms to solve problems that they are interesting in our domain. And this is something that it is super, I think. However, on the other hand, we can think that this kind of algorithms, they can give us a lot of insights and make us understand. I will try my best. How, for example, patients or give us biomarkers for particular kind of things. And of course, you discussed also between you and everybody discussed about ChatGPT and how we can use it and how we can apply it. There is already literature on how good ChatGPT, for example, is working on diagnosing different kinds of symptoms. And indeed, this is again a huge model that it has been trained on a very big amount of data, and currently it gets a lot of attention. So once more, I would say that the engineers, they were a little bit faster than the lawyers, because again we have the algorithms, but we don't have the way or the frame to use them properly and to adapt them in a safe way into our everyday life. And okay, this is one more actually algorithm that it has been actually published 1.5 months ago. and it has been published from Meta and Facebook, and indeed it is a huge model that has been trained again on a huge amount of data, and it can give us annotations and segmentations of objects in a very, very accurate way. So again, there is a lot of attention on how we can use this algorithm and adapt it, and there are already papers, even, again, this paper is on arXiv, it's not even peer-reviewed, and there are already papers that they are trying to adapt it into the medical domain, and they can actually indicate that we can actually use this kind of method and we can perform very well with respect to the current state of the art. So overall, I wanted to discuss some kind of new kind of learning that we can use, but I think I don't have the time to go into details for this. What I would like to say, closing this very short presentation, and you can ask me more if you want to, is that actually deep learning in general, it will really affect precision medicine. I am really convinced about that. Currently, the algorithms, they are not as well adapted into the clinical practice as we would like to. They are more in the research phase, even today. So actually, we need, again, to understand why this is happening and how we can facilitate this process. These kind of new models, that they are these large models, I think, in my personal opinion, is that they are very powerful and they can really adapt and give insights on the medical domain. So there is a lot of kind of research directions how we can adapt them and how we can use them on different tasks. And of course, I saw this kind of cell cover about cancer that indicates that all this kind of thing that we do, it's really difficult, and we need a lot of interdisciplinarity. We need engineers, we need doctors, we need to work all together in order to untackle not only the algorithmic, but also the medical problems that we have. So that's all from my side. Thank you very much.